To be here. Hopefully this is useful to everybody. Thanks, Tomas, for that presentation. And before anybody asks where I'm at Tingley Beach. It's our wonderful local beach here. Usually I get that question, and I put a bunch of slides, so I'll go kind of quickly, and I guess we can do questions in the chat, or people can just stop me and we'll go from there. My understanding is we have like an hour sharp, so I'll try to be roll with that as quick as I can. All right. So like any kind of academic thing, we need goals for the presentation. So hopefully a better understanding of social determinants of health, how providers can interact with social determinants, and a short understanding of health promotion. Health promotion is the process of enabling people to increase control over and to improve their health. So health promotion is what I've been working in since 2001. And so my job is not to improve other people's health, but to help folks improve their own health. Some of the prerequisites originally listed were peace, shelter, education, food, income, stable ecosystem, sustainable resources, social justice, and equity. Clearly, this was all written before our current situation of things in the world these days. This was originally put together in the 80s. Teaching social determinants is important because individual behaviors, while they do matter, they're a small amount of the disease in our society compared to societal factors. The individual behavioral health approach limits because it doesn't address why people are doing the behavior. For example, smoking, right? There's the stories in research of like, there's moms who smoke because that's the one time they can get a break from their family, right? Because no one's allowed to be around them while they smoke because of the secondhand smoke thing. So gives them a break, but then it's causing other issues. And a lot of times we end up blaming the victim when we're thinking of individual things as opposed to like, what are the bigger social issues? There's a semi-famous story in public health of the upstream and downstream river. I used to have to explain that a lot. I think most people get that story somewhere in medicine and health now. But essentially that there was somebody noticing babies floating down a river, and while this entire industry of fishing them out the river and saving them was developing, somebody decided to go up the stream and find out why were the babies going into the river in the first place. And so health intervention, health services, which most providers end up doing, addressing social determinants of health, which is looking at what are the policy and environmental factors, and social determinants of equity, why some groups get more things or less things than others. So here is a quick graphic, and I don't like to read slides to people, so if any time I'm going too fast, feel free to tell me, but you have to say it verbally because I'm on the split screen thing, so I can't see the chat while I'm doing this. So a lot of the New Mexico public health folks worked with a group called Health Impact Partners from the early 2000s. And so, this looks at health as a series of things. There's the factors that we can't control, our age, physical, gender, genetics. Things we can change, our behaviors, And then it goes out to the public service and infrastructures, right? Living and working conditions, and then the larger social, economic, political factors, right? We can't control our age as much as people want to, but and we may have some control over exercise and diet depending on our living situations. But then it gets harder to control, what are the infrastructure and public services of your community. It's harder to control your living and working conditions in some ways. And then, clearly it takes a lot to change social, economic, and political factors such as poverty or racism, segregation, those type of things. Other folks wanted to look at what are the specific determinants of health equity, and they came up with this model where you're looking at going from individual to kind of societal things of racism, classism, sexism, etc. And again, these were developed, between the 90s and the early 2000s. So if there's newer of these that anybody knows of, feel free to send them to me. Clearly, I haven't done any new research for a while. And so there's a continuum, right, where we're an individual, we do what we need to do, or we're service providers, right? We address people in that sense. Or they use activism. I would use the term organizing, but addressing structures of society as a whole. So how do providers interact with poverty? And you can screen, assess, and intervene. The screening is hard, and some of this has started to happen since we first started doing this kind of work in public health. So there are screening tools that some clinics have, and it's really not like the physician that does a lot of this interaction. It's other folks in the clinic. But really, there are places now where you get asked about, stable income, stable housing, those issues, right? The one that's most common, I think, is the, are you safe at home question, which really is one of these questions, right? And these pictures are here in Albuquerque. So it really is conditions that some folks that you may see live with, right? And I'll have to look at these numbers again, because again, this was, it's been a while since I've updated my slides. But at one time, 14% of county residents and 22% of the residents, specifically in the international district, were under 100% of the federal poverty level. And so the different adversity and stress that comes from that, right, impacts people in different ways. And so that's why it's important to know this, right? Somebody may be smoking to deal with stress, not just because they like smoking or because they think it's cool or any of those kind of things. People could be having a hard time sleeping because they're worried about, paying the rent, those kind of things. And so who should get screened? Everyone should get screened. Right. And so people struggling, everyone struggles to make ends meet, or most people do in the US. So it's important to find out what things are going on with folks. So there was a set of screening tools that I don't currently have, but they were developed by doctors in Canada. And so they would ask questions on income, housing, um, as well as the standard smoking, alcohol, substance use, but also just food security in general. Do they work in a risky job? Um, do they have social supports? Do they receive benefits? Um, my family, when we were university students, uh, applied for food stamps and a ton of paper that you fill out, and we were a family of four. Uh, both my wife and I were going to UNM and working at McDonald's, and we received $23 a month. So you can ask a person, do they have stamps? And that's one question, but the other question is, are you getting enough food stamps for what you need? From there, you do risk assessment. There's still an effort to learn how to best deal with poverty. And poverty is just kind of a stand-in for general social determinants of health. We know that poverty has a huge impact on health. But what we're saying here is, that poverty may be a way to trigger screening on other behavioral health or behavioral health and health concerns. And how do we do interventions? Hold on just a second. Uh, so, here's some things that you probably know is that children growing up in poverty tend to have more of these issues here. You know, we talk about the high youth violence rate in Albuquerque, and we see that children growing up in poverty tend to deal with homicide more, both as victims and as perpetrators, right? Unintentional injuries and all of these other things. I know docs at some of the clinics in Southeast Albuquerque talk to me about how frustrated they feel about the number of young people that they diagnose with diabetes. Um, that they feel is much higher than it should be. I just clicking. So what do providers get to do about community health? And I think, it's a spectrum, right? You can be advocates, you can participate in different things going on. You can organize, you can educate. I know there were people demonstrating outside at one of the dollar stores because of the plastics that were being used in the toys that were being sold there. Somebody had tested them and found, they were more toxic than the toys that would be sold in other stores, basically because they're toys that were being tossed out, right, and sold at a discount. And what was helpful was to have, folks in white coats show up. And the same is true at city council. We've had times we've gone to city council to talk about issues, and if we could get a doc to show up in a white coat, they carry a lot more weight than myself as a public health worker. At the end of the day, there's just that credibility around knowledge that physicians have and other providers have. So this is just um, an old slide around what numbers were estimated to contribute to the early death of people in the U.S., right? Low education is huge, as well as, the acute myocardial infarction. Lung cancer is huge, but low social support is still higher than that, right? Racial segregation was considered to be higher than that. And so again, this is not like a direct cause, but these are the social causes are just strongly correlated. If we were to get everyone from all different populations to have the same mortality rate, right? It would do more, maybe 5 times as more than perfecting technology. By the work that you all do, and looking at economic and social equity, right? You all investing in that, you would save even more lives than you already do. So equity is not the cool word that it used to be, but still it's important. And Tomas shared my thesis, right, is that health equity requires social equity, and social equity requires equity in power and resources. And that's going to require all of us to participate in different ways. Mostly some within our work days and a lot outside of our work days. Right, 119,000 deaths were attributed in 1 year in the U.S. to income inequality, right? There was other factors that they modeled. Here is World Health Organization showing what the gradient looks like in most countries. And the gradient is fairly similar, even if that the raw numbers are very different, or the absolute numbers. So it just shows how this is kind of a universal trend, right? Sometimes we want to say, well, but is that true in New Mexico, or is that true here in the US? And it's fairly universal. Here's numbers for Bernalillo County, diabetes, broken out by Hispanic and non-Hispanic, male and female. And you can see that the higher the poverty level of the census tract in which people lived when they died, gives you very different outcomes. And there's a quick graphic of the city, shows the concentration there. Politics is part of this. May not be as fun to talk about this now as it was before, but it's still important. Dr. Navarro and a group of folks looked at industrialized countries over 50 years, and here's some of the things they came up with. For every percent in increase in votes for social democratic parties, right? Labor Party, Social Democrat, Socialist, infant mortality declined 0.15 per thousand births. And for every 1% increase in population participation, it dropped 0.13. In the US, we don't have any federal level social democratic parties. And so that top part is not really applicable in the US. But the bottom part is the more people vote, and the idea behind this is that the majority of people are working class, and so the more they vote, the more likely politicians are going to be trying to work to gain their votes. Election systems are part of this, right? Outside of the US, most Western political systems use some form of proportional representation. And because proportional representation forces collaboration, in general, there's an attempt to reduce income inequalities versus countries with two-party rule. We've seen this kind of break down a lot in the last 10, 15 years. Countries with more union participation, more union members, usually get better health outcomes because folks have access to healthcare or retirement and these different things that improve health. This is a slide about mental health, right? The higher striped one is people who are on no contract. They're just kind of working cash kind of work versus folks who have, permanent and stable kind of work. And you can see there's a gradient. It's interesting, and I don't know the details on why there's this change here with women. But those are things that the World Health Organization put out when they started working on social determinants of health. The US, we have what's called privatized politics, right? The government doesn't pay for elections where everyone has equitable access, right? It's basically whoever can raise the most funds privately has the best chance of winning. And so Navarro here is saying that that's why, universal healthcare is not happening in the US and lots of other things. I believe it was 1976 when the first poll in the US showed over 50% of the population thought universal healthcare was a good idea. And, we're 50 years down the road and still not very close to universal healthcare. And so the argument is that having election systems that require fundraising leads to that type of outcome. Right, and so here's just a quick guide of that. Whatever we call politics leads to parties in power, which leads to policies and gives us the outcomes we have. Here's just an overall broken up by different groups of poverty and all-cause mortality in Bernalillo County. So this is us here. And we see, again, the gradient is fairly consistent, except for here with indigenous folks, tribal folks. This is from the 2000 census, so clearly it could be updated. But here's the poverty level, with red being the highest at over 20%, and the dark green being the lowest at 5% or less. So we can see clearly concentration of poverty, though it's not completely, broken up. There is definite concentrations. I included this slide because I think it's important. So they broke out factors, original language, culture, access to land, ability to practice your original religion. And there was a few things that I should have put on this slide. But you see that the suicide rates, the more you're disassociated from your culture, the higher the suicide rates are. and the more factors of your culture are present and existing, the lower the rates go. And I think that's important to think about how assimilation and different cultural practices, as well as different government policies, interact with tribal folks and other indigenous folks' cultures as far as health outcomes. Okay, oops, that's a duplicate. Okay, this is the slide I wanted to make sure I kept. So if we gave everyone the health outcomes of college-educated folks, we would save 8 times as many lives as we would in investment in medical advances. And so what this is just telling us is that programs such as giving people free access to college education will save a great deal of lives as people get more educated. All the different benefits, the social circles, as well as the income and access and information is important. All right, so what are health enhancing policies? Living wage, any increase in minimum wage, right? Affordable housing, increased recreational space, a fair taxation system, walkable environments, public transportation, and what else? I'm pretty sure that's close to the end of my slides. I was much more nervous and talking way faster than I thought I was going to, so I cut out a bunch of slides thinking I was going to run overtime, but I guess this will leave us time for conversations.
If anyone has comments, please feel free to unmute yourself, or if you'd like to put them in the chat or questions.
I usually like to have folks introduce themselves, but I was worried I was going to go overtime, so.
We have quite a few on the
yeah, it's a great turnout. I don't think we can do introductions.
Yeah, would you be able to share a little bit about your work with the Health Equity Council and how this comes into play overall?
Yeah, and so there's my email. I'll put it in the chat so I can stop sharing here. And then I can move this and look at you all as opposed to looking to the side. Yeah, so health councils were developed in 1992 by the state as child and maternal wellness councils. They became community health councils in the early 2000s. And then around 2010, the state defunded all of the county health councils. And ours landed at Bernalillo County government for a few years. And then in 2015, we became a nonprofit. And recently, the state has started to fund them again. They're currently wanting to transition them to behavioral health councils because that's the thing that's exciting to the state these days. For our individual health council, we're not funded in a way that makes any sense. We have funds. So we work on healthy eating and active living. We partner with folks at Presbyterian through a CDC grant and other community folks doing stuff. And I'll answer the things in the chat after I finish this section real quick here. We do harm reduction work, right? We train people on opioid overdose reversals. We do prevention work around substance use. We do some policy research work. Dr. Roybal, who's on the call with us today, is part of the Health Council. We do a lot of different advocacy work, outreach, and education. We're trying to figure out some capacity to build environmental health, youth work, and communications work. I would love to have an Indigenous health full-time staff person, but at this point, we're just fighting to keep the doors open as we're getting impacted by health health cuts, budget cuts that are coming from the federal level. I guess there's no way to say that in calm, nice terms. But yeah, so we're being impacted. There was a grant that we had for youth prevention work. There was 60 grantees in New Mexico last year, and there was 0 this year. And so basically that grant nationwide saw a 99% reduction. So, and I'm sure that this impacts folks. So let me look at the questions. Can I suggest how we incorporate this into next generation mental health providers? What would you like to see? Where has training been like? And one of the things we do is we participate in the local collaborative tool, which is the Behavioral Health Collaborative. And I have not been active there. We have a staff person that's doing that, a contractor. But how would we incorporate this training? I think there's 2 ways. One is to make a short unit of however many classes folks think are enough. I'm not going to get into it. It's never enough. There's so many things folks need to learn. But making this like a small unit, or having ongoing trainings, once a quarter, once a semester, once a year. As far as social determinants go, the Health Council would be more than happy to continue to do that. My commitment is, even if we get shut down due to lack of budgeting, which would be our worst case scenario as a Health Council, myself as a public health person would be willing to work on this, for a few burritos and some time to get out of the house if things were to get that bad. I think where training is always lacking is just how do you have enough time to fit everything in? That's important. And Dr. Roybal, I see your hand up, and then I'm going to read these other questions after that.
I have a response, I guess, to some of the questions. Let's see if I'm unmuted. So good afternoon, everyone. My name is Carmela Roybal. I'm actually a fellow UNM faculty member, the executive director of the Native American Budget and Policy Institute at the University of New Mexico, and I've been part of the Health Council prior to my role as faculty at the university. And I've been with the Health Council, I want to say it's maybe 6 or 7 years. And so a lot of what I guess I kind of just wanted to help Enrique summarize the gap that the councils fill between providers and community. So there's this massive gap to access to resources. So community goes to the Health Council with these types of issues, and the council can help navigate, other resources. So for example, social determinants of health, do you have a safe place to live? It's really important. So this is your resource as providers, to say, okay, I have a phone number I can call, and we can start to work on resources or connect to others. So the Health Council, this is something that I've learned through the years, is that the safety net network attached to the Health Council for Bernalillo County is immense. So this is everything from a food pantry to all of the different organizations related to healthy gardens, eating, the housing, environmental departments, Community might come in and say, well, I don't know if everyone's aware of this, but some of the data that's been pulled is, the #1 reason for truancy in the city of Albuquerque is actually asthma. It's not parents, it's asthma, it's breathing. So a lot of this critical data and programs that are funneled through the Health Council, part of the Health Council's network, really kind of show us the root causes of what you're seeing in the clinical setting. And so we're able to address things and help move things. So along as my other hat is I'm a senior advisor. I work for the Agency for Healthcare Research and Quality. I work there for the director. I've been there for several years. We are on a shutdown, but I continue to work because the work that I do is building out some very comprehensive national programs to really think about ways that we can integrate all of these knowledges, determinants of health, and all of that great mental health services into primary care. See, many of you will see this in your primary care settings, I'm not sure, but you'll see that you're dealing with a lot of these other issues related to mental health or the social determinants of health, but we're not quite set up to kind of navigate from that space, right? So you might see many individuals come in, not follow the regimen, not take their medicine, not follow, or disappear, and get seen in the ER later on, or there's, a lot of different things that happen along the way. And so I think that there is a lot of connecting the gaps and creating that web of safety. And I think that's the role that the health councils really play. So bringing those public resources into the purview. And so it's more of it's kind of building this web of community. And so I know during the COVID pandemic, the Health Council was central, bringing federal resources. Within a week or two, we have 36,000 test kits on the ground in the homes. So that's the work of the Health Council. So there's some massive endeavors that go underneath this council with this really awesome group and network. And I don't know, Enrique, if you want to invite people to, there's a monthly meeting where you can see all of the different individuals and kind of network that work in all of those different spaces, from early education, early childhood education to housing and HUD. And so really bringing all the SDOH factors together in one room to talk about. And so you'd be so surprised how many resources are actually out there. It's just making that connection. So thank you, and I'll hand it back to you, Enrique.
Great. I'm trying to keep up with the chat here. Good things. Yeah, so my email is there if you want to be part of our monthly meetings or connect with our behavioral health work that we're doing. I think that would be great. Joy McQuarrie asked a key question. Part of the reluctance around screening for social determinants is the concern that problems will be unearthed when there's no resources to assist. And that's huge, and that's very real. So I think part of it is looking for whatever resources you can find and starting there, right? UNM used to have, through various agencies, what were called pathways navigators, and their job was to help people deal with social determinants of health in a very kind of structured way. And so if that program still exists, I'm not sure that it does. I like many people, I lost track of a lot of things during the pandemic. And so I'm not sure if that program existed. I know that the folks that worked there that I knew no longer work there. So at UNM, so they've retired. But if you know anybody that does any kind of social services, housing, food, those kind of things, beyond what you do, connecting with them before you start doing these screenings may be a useful thing, right? But it's also useful to just know, like, why a person, may be dealing with what they're dealing with. And so
I'm Joy McQuarrie. I was the one that wrote the question. I appreciate the answer. And so I guess my mind was going in a couple different directions. So one, I'm with Indian Health Services. And so you know, so many of our population is very rural, very remote, like just having the gas money. There's often there can be a lot of turnover. So even if maybe someone had built the resources and had the relationships, maybe that person leaves and then you lose the institutional knowledge. And so that was just thinking about that. But then the other half of my question, honestly, I was, you know, like I know a lot of the data for suicide screening, and there's data that shows just the act of screening in itself can be therapeutic. So, you know, so I was just sort of wondering, like, just asking these questions, just inquiring, just wondering, might patients find that to be like, oh, someone's listening, someone understands? Or I could also see it going, well, that was humiliating, or I filled out that form and no one said or did anything about it. Like, I just really had truly an open question about the impact, like, you know, the effects of screening when there's no resources. And, you know, maybe it's positive. I mean, I have an openness to that. I was just curious if there's any data.
I've not seen any data specific to that. Again, with this, the idea of screening originally came from folks who do physical health, and them starting to do that. So I will look into that. So that's an area for me to grow and find out more information. Because I think that's important, because it's true. Sometimes just being asked something helps you, or it could make you feel worse, right? And so
Yeah,
that's,
I'm just wondering. Yeah, exactly.
yeah. So, I mean, again, as a committed partner, that's something we'll try to find out. Dr. Roybal will hold me to that.
Yeah, there's actually a lot of resources that just aren't getting communicated. And so that's another thing. And maybe, you know, building kind of a resource guide that's available that people could call, or that you could actually hand to a family, or that there could be some, but see, without knowing all of those gaps, there is a lot of SDOH data that will show you kind of like maps of all of the kind of measures, and can map it out across the city. So you'd have like an idea just going in, but maybe having some sort of resource list that you could, you know, share with providers, or you could provide for families. But there are actual resources in a lot of different spaces that don't get utilized. They're just not utilized, and a lot of that is just getting that information out, and it changes a lot with like funding and how people are able to provide all of that. But we're definitely in a very hard place right now in New Mexico, definitely in Albuquerque, and I work with Indian Health Services regularly. And yeah, we see that a lot, and we do see very, very high populations in the city of Albuquerque, in fact, really dealing with homelessness. And so access to care, you know, it's a critical thing to actually ask, or to even think through ahead of time. Should somebody come into our office and not have safe housing, what are the resources in Albuquerque? And then maybe that's something you convey to Enrique and, you know, the city. That's something that we bring up with the city, and how do we build houses? So through all these different, like, communicating back and forth is how a lot of these initiatives get built. But until, you know, the conversations happen, and I know there's not a lot of time for providers to relay that information, but even having some sort of tab on it within UMH would be really helpful, I think, for, you know, providers just to understand 40% of the population that walks in the store will not have adequate. The majority are renters, and they're going to be within this social demographic, just off the top. So there used to be training in med school, and it was done by a lot of the some of the teams at UNM, who they really kind of instruct like the deep dive into the social determinants, so people could actually have kind of be prepared. Like, these are what's causing it. Like all of this asthma, right? Students aren't going to school. That's really important data to have. So there's all these different pieces that I think need to be like dove into to kind of really understand the population on a different level. Because I'll hear a lot of, you know, this is the cause, you know, it's families, it's parents, no discipline. It's like, actually they have asthma, or they're having breathing issues. And then when we kind of look deeper, we're saying, oh gosh, it's right next to this plant. There's massive uranium cells that are bleeding into Albuquerque. There's a lot of things happening that are not taken into consideration, you know, within all of these. So those are the determinants, right, that are going to change. Same thing with maternal mortality, infant mortality. All of these different pieces are completely impacted by SDOH, right? All of those social determinants. And until we kind of do a deep dive and kind of really understand, it's really hard to put your finger on the mark. Thank you.
Yeah, and I also see that, again, the question was just if we don't have the resources, is asking the question useful or not? We'll dig into that as well. I think that's important to know, right? We don't want to just we want to know, like, is it just going to trigger folks and make things worse, or is it going to make folks feel like somebody's trying to understand what's really going on? And there may be info on that we haven't dug into yet. And all feedback's valuable. I have pretty thick skin, and how hard can I take something when I'm hanging out on Tinley Beach?
We did start at UNM on the other campus, patient navigators for cancer patients, so they don't have vehicles and they don't have transportation to get screened or to get care. So we started a program. It's non-clinical. It's just community members that they need a ride, they need to get screened, they need access to care. They drive them to all of these points. They help navigate the medical system. They call, set appointments. They call IHS. They call the VA hospital. They try to, so they're navigators basically. But we started that at our institute. So we have several on the ground within some of the pueblos so that we can actually provide, or so if they had a diagnosis, they'd have somebody to actually, the provider can call and connect, and or if they get screened or we help them get screened, or whichever direction it goes, but they actually have somebody that can physically show up and pick them up and all of that stuff, and all of those costs are covered under our program. But we have to come up with things to make it happen. So on larger scale, it would be things like I think there's ways, but it definitely hasn't been scaled out yet.
And I've also am a supporter. There's folks in my family who are in the behavioral health systems in different ways. So I'm more than happy to talk about any of and all of this stuff.
Well, it's still open for questions. We still have time. If not, we can thank you, Enrique, for coming to join us and sharing your work. And if there's any last questions, there's a comment in the chat.
Yeah. No. Yeah. Nursing home care is a whole intense situation on its own. I think
Hi there.
that
I'm the one who asked the question. So,
yeah.
I mean, I'm just wondering if you have any suggestions. I mean, when I worked in managed care, it was very, very hard to get people into nursing homes to accept people with mental illness. And we see people getting stalled out in geriatric units because of this. And so in name, they have this benefit. But the barriers that are put up by private nursing homes to prevent patients from being admitted, or even the fact that a lot of nursing homes won't take anyone on Suboxone, even if they've been sober and they're doing well on that medication. It's very difficult. And then I was told that there wasn't assisted living available as a nursing home, as a Medicaid benefit. And several years into the job, discovered, I had a patient who I knew didn't have money and somehow ended up in assisted living. And by tracing it back, I kind of figured out how that worked, but was being told by the company I worked for, oh no, we don't pay for assisted living. And so I'm just wondering if you have any any suggestions for, where to even start in this process, because it's really discouraging to see very medically ill, mentally ill people living on the streets when they are, at least on paper, entitled to a safer housing situation. And these are people who want to live in a nursing home or assisted living, who are accepting of that, not people who are refusing. So
Right.
I know it's a big question, but if you have any suggestions, where to go. I tried to get on some work groups through the state, and just have not been very successful in access.
Yeah, I think that would sadly require a ton of policy change work. Insurance, a lot of companies are just, run off what the risk is, and whether the risk is real or perceived. Once the risk idea is put out there, then they shut down a lot of options. And then sadly, people will blame everybody but the insurance company as to like why there's folks living outside, or why there's elders living outside, all of those kind of things, which, has lots of funky repercussions that happen there. But yeah, that's the main thing, because I know without policy change, right, and some budgeting, that's really not going to change. So I don't know if there's a group of folks that are interested in spending a lot of their free time harassing folks for that. But I think it's where things have to go, unfortunately. And right now seems like probably the toughest time to make those kind of changes, but starting on that work, it's got to start sometime. Might as well be now. Because I get what you're saying. I don't have a ton of experience. I worked at a place called Parents for Behaviorally Different Children in the late 90s. And so my experience was mostly with kids. But yeah, I think I definitely have folks who are aging into the elder psych sense, and still part of the behavioral health system. So I'll on one level or another be paying more attention to that. And now that you brought it to my attention, I appreciate it, because Tim, go ahead, Tim. All right, looked like that was Tim's iPhone that was communicating. Thanks, Paula. And I've known Charlene for a while, so I'm glad she's on screen.
Okay, if there's no other questions, comments, feedback, I want to thank you, Enrique, once again for joining us for Grand Rounds. Thank you for all the information you provided. And so much
Thank you.
gratitude.
Yeah, I'll there was one duplicate slide. I'll fix that before and send you the slides, because I know people often ask for those after the presentation.
Great. Thank you. Appreciate it.
Yeah. All right. Well, I hope to come back at some point. And appreciate you all, and look forward to continuing to work in behavioral health.
Thank you. Absolutely.